They are also given a name called brown sugar because they have a brown in color appearance. See color. That's why they are called brown sugar in general layman term. So before going to this analgesics that results into selective pain without altering consciousness, narcotics, those drugs possess both analgesic and sedative property. Then we classify it as a narcotics. So opioid refers to the drug in general sense, natural or synthetic with morphine-like action, and we have non-opioids that is NSAIDs. So I will not be discussing about the histories and other these things again. So morphine, they have a like morphine, we have a endogenous opioid peptide. They are called endorphin, dynorphin, and enkephalin. And they are the precursor proteins. They are obtained from pre-melanocortin, pre-enkephalin, and pre-prodynorphin. They are obtained from these compounds. So they are natural opioid analgesics, endogenous opioid analgesics that acts inside our body naturally. They act on the alpha, mu, and kappa receptor and results into analgesic effect on our body. So our drug morphine acts, just to say, they act as an agonist to these opioid receptors that is done similarly by the endorphin, dynorphin, and enkephalin. So we have three different groups of opioid receptors: mu, kappa, and delta. Mu, kappa, and delta. They are all G inhibitory type of proteins. G protein coupled, GI coupled, which inhibits adenyl cyclase. Inhibition of adenyl cyclase decreases cyclic AMP. Decrease in cyclic AMP decreases calcium level. There is no efflux of neurotransmitter from the neuron. Generally, these receptors are present in pre-synaptic fibers, not in post-pre-synaptic fibers. That's why they result into release of neurotransmitter that as done by the alpha 2. If you could remember and compare with alpha 2. Alpha 2 is also results in the inhibition of release of adrenaline and noradrenaline in pre fibers. So similarly, opioids, they have mu, delta, and kappa, and their activation by either endogenous compound, endorphin, dynorphin, or enkephalin, or by the use of morphine and morphine-related compound, will result into decrease in pain sensation, especially pain sensation. This is the theme of the mechanism of action. So, to let me come with. We have two different compounds that are present in from poppy plant. They are called two different alkaloids are obtained from opium. They are phenanthrene and benzoisoquins. Phenanthrene and benzoisoquins. Among phenanthrenes, morphine and codeine has a analgesic property. Morphine and codeine has an analgesic property. Whereas thiamine and other benzoisoquinolines like papaverines, noscapines, they do not possess any analgesic property. They are non-analgesic. Only from the phenanthrenes, morphine and codeine possess analgesic property. Remaining all benzoisoquins, isoquinolines, and thiamine, they do not have any analgesic property. That's why they are not used as an analgesic. Noscapine can be used for the cough suppressants as a cough suppressants. Remaining other semi-synthetic, they all have a analgesic property. Under semi-synthetic, which are obtained from the structure of morphine, that's why they are called semi-synthetic, like heroin, folcodeine, ethyl morphine. They all have analgesic similar efficacy and pharmacological profile with morphine. Whereas synthetic pethidines, methadone, fentanyl, tramadol, and dextropropoxyphene, they all act as a analgesics. These are drug classification. Let me come with morphine. Start with morphine is a prototype. It's a prototype among opioid analgesics. Morphine being principal alkaloid in opium and widely used till today. And it's a prototype drug. So let me come to the chemical structure of morphine, which is as shown here. Though you may not require the chemical properties of morphine for your exam, but also if you could know could understand to some extent, it would be very helpful, because most of the drugs, since they are semi-synthetic, are derived from by the structural activity by changing the functional group in this parent compound morphine, like ethyl morphines and heroin. They are all obtained from morphine. So let me come. They are pentacyclic alkaloids. That means they have 5 ring structure: 1, 2, 3, 4, and there is one here. Yeah, with nitrogen, 5 ring structures. And there is 2 hydroxyl group at 3 and 6 positions here. Hydroxyl group 2 and 3 and 6 position, and fourth and fifth position are bridged with oxygen, whereas there is nitrogen at the 16th position here. There is a nitrogen at the 16th position. If you could count 10, 11, 12, 13, 14, 10, 11, 12, 13, 14, 15 and 16. So at the 16th position there is presence of nitrogen. It also has a, see, by changing it by adding alkaline, it converts to naloxone. What happens if you could replace this nitrogen group with any alkyl group, then this morphine will be converted into naloxone, which is an antagonist to morphine. So it goes from a agonist to antagonist just by changing this nitrogen group by methyl group or any alkyl group. See, this is how the drugs are derived or drugs are synthesized. So these are all about chemical structure. So you should remember here is one nitrogen group and here is hydroxyl, because most of the metabolism takes place on this hydroxyl group as of adrenaline and noradrenaline. त्यो तपाईले याद छ कि छैन, adrenaline noradrenaline पनि यो कुराहरु आउँछ है, पढ्नु होला. So receptor stimulation, we have mu, kappa and delta, three type of receptors, and the effect depends upon the stimulation of all these three kinds of receptors. Like for mu receptors, if mu receptors are stimulated by morphine or any endogenous compound, they result into PEARPR. If it would be very easy for you to remember, that's why I have made this mnemonic. So P for physical dependence, E for euphoria, feeling of well-beingness, that is euphoria, A for analgesia, and R for respiratory depression. These are all mediated through mu receptor. Whereas by kappa, SAM, that is sedation, analgesia, and meiosis, that is pinpoint pupil constriction. Whereas delta result into AR, that is analgesia and also release of growth hormone. These are all mediated to delta receptors. So effects by receptor stimulation like mu, PA, kappa, SAM, and delta AR, if you could remember. So see the opioid receptor distribution. The CNS distribution is not uniform for opioid receptors. They are at areas concentrated with or concerned with pain. That is receptor location being with the highest concentration area, like highest cerebral cortex here, mostly found in cerebral cortex. Then comes amygdala, septum, thalamus. Consequently, they go under thalamus, hypothalamus, midbrain, and then towards the spinal cord. These are the receptors distribution of opioid receptors. So let me come to pharmacology now. Pharmacokinetic. Opioid, I'm talking about morphine. They are readily absorbed from GI tract, nasal mucosa, and long subcutaneous, intramuscular, and obviously intravenous. No absorptions are needed. And widely distributed. They are plasma protein bound, 30% are plasma protein bound, and free morphine accumulates in kidney, lung, liver, and spleen, but they do not persist, they do not remain in the tissue for longer duration. The CNS is the primary site of action, analgesia, sedation, as well as they are very much teratogenic. That means they should not be given through during pregnancy. So let me come to the absorption. Morphine, if given through oral route, they undergo high first pass metabolism. Morphine undergoes high first pass metabolism. They are metabolized in liver, and that's where the preferred route is not oral for morphine. Morphine is not given through oral route, being most corrosive, irritative. They have most adverse effect profile related to GI system, nausea, vomiting, constipation, and also they have very less absorption. Though they absorb readily, but their availability in the systemic circulation is very low due to the first pass metabolism or metabolism due to liver before reaching to systemic circulation. That's why morphine is not recommended by oral route. So we have other route like intravenous. Mostly they are given through intravenous route. Now let me go to metabolism. The metabolism, the conjugate, they undergo conjugation reaction, and conjugation takes place with glucuronide acid, glucuronide conjugation, and the morphine 6 glucuronide are more potent than morphine. That means active form of drug are biotransformed into more active form. Once they are metabolized and they are converted into 6 morphine glucuronide, that means this compound 6 morphine glucuronide has more potency and efficacy compared to morphine itself, and they are excreted by kidney. Its half-life being 2 to 3 hours, and also does not persist in the body, but they are available in the body would be up to 12 hours, more than 12 hours, being because they undergo enterohepatic circulation. Then again, they are converted into morphine 6 glucuronide, which is the main excretion product, and this morphine 6 glucuronide also has some efficacy and potency with the opioid receptors. That's why the efficacy of morphine is very much high. And they lose 90% in first day, and duration of 10 mg dose is 3 to 4 hours. 3 to 4 hours. See here, structure of morphine. Morphine, two hydroxyl group on two side, and there is a nitrogen group with methyl group on this side. So substitution of this hydrogen, both hydrogen by methyl group becomes codeine, which can be given as antitussive, and they protect from the glucuronidation, because most of the glucuronidation takes place in hydroxyl group. So they become resistant or immune to glucuronidation or metabolism. So now they can be given through oral route, that is codeine. Codeine is a drug which is preferred through oral route, because now they do not they are resistant to glucuronidation, because they do not have hydroxyl group. This pH is replaced by methyl group, which becomes codeine, and codeine now does not undergo first pass metabolism and can be given through oral route. But in the case of morphine, we cannot go through oral route. And demethylation, whereas glucuronide morphine has still analgesic potency. Morphine oral is not given due to erratic oral availability, significant variable first pass effect from person to person, and have intra-specific species effect. That means same dose will vary in person to person, in day to day. IV morphine acts promptly, and its main effects is the central nervous system. So CNS is the primary site of action of morphine, which results into analgesia, sedation, euphoria, mood change, and mental cloudiness. Cloudiness भनेको brain fog भन्छ यसलाई, जस्तै blur vision भने जस्तै blur thinking. In simple term, you know that there is a term called blur vision. Similarly, if you have a blurred thinking, then we call it as a mental cloudiness, because we can, after the use of morphine, a person cannot concentrate on certain things. That is called reaction time changes. There are different effects are seen. That is called mental cloudiness. So morphine changes our reaction time, our perception of pain. See, morphine given in severe pain is tolerated more when person is given morphine. Where relieve all type of pain, sharp, stabbing, shooting pain, also relieved by the morphine. Whereas morphine given to a pain-free individuals. See, morphine given to pain-free individuals first experience dysphoric, which is not experienced in person in pain. So it should not be used by unless it is required. So morphine sedation, morphine causes sedation effect but no loss of consciousness. Morphine results into euphoria, senses of well-being. It is due to the release of dopamine. It is not due to the stimulation or inhibition of mu receptors. It is due to the influence, and through the mu receptors they result into release of dopamine that results into euphoric effect. That is the reason why morphine is being abused. On respiration, they have a depression effect primarily, and continuous depression of respiration related to dose. They decrease the rate of respiration, they decreases the volume of respiration, and also they decreases the tidal actions. This is due to the mu receptor activation produces respiratory depression, which increases in dose can cause further respiratory depression. And CNS becomes less responsiveness to partial percentage of carbon dioxide. And this is why they thereby causing a build-up of PCO2 in the body, causes irregular breathing pattern, and one will see periods of apnea. That means cessation of breathing in a higher dose. Nausea, vomiting, main adverse effect, major adverse effect. In case of morphine, you should never forget again, nausea, vomiting, and constipation. You should always mention nausea, vomiting, and constipation in case of morphine, not diarrhea. We have a opposite here effect here. One, nausea, vomiting, another is constipation. So now we know that nausea, vomiting is due to the stimulation of CTZ in the area posterior of medulla. Stimulation by the stretch receptor results into nausea, vomiting, and there is also availability of in higher concentration of mu opoid receptor in the enteric nerve plexus. In gut also there is a presence of, there are lots of mu receptors which are due to stimulation will result into constipation and other GI related problem. They are involved in motion sickness. So pupil size obviously results in pupil constriction, which is called pinpoint pupil or meiosis. This is due to the kappa receptor effect. Though pinpoint pupils still are responsive to brighter light. So this is due to the inhibition of stimulation of oculomotor nerves, canal 3, Edinger-Westphal. I think it's Edinger-Westphal, maybe. Let me see. So it is due to the Edinger-Westphal nucleus. If kappa receptor is blocked, MADRS is from the sigma effect will be seen. So that means it suggests that there is a equal significance of both sigma and kappa receptors, and atropine partially blocks the effect, indicating that there is also the involvement of parasympathetic system. So in case of acute overdose, which is in the high dose overdose situation of morphine, excitatory and spinal reflexes, high dose of many opioid causes convulsion due to the stimulation of sigma receptors. Sigma receptors. They result into fall in blood pressure due to release of histamine. Say cardiovascular effect of morphine leads to vasodilation. This is decrease in blood pressure. So vasodilation is due to the effect of histamine. They result into release of histamine. That's why morphine can cause into itching, allergic reactions due to the effect of histamine. They also result into vasodilation, especially peripheral vasodilations, which may result into fall in blood pressure. They also suppress the central adrenergic tone and suppress the reflex vasoconstriction, which ultimately inhibits the cardiovascular system and will result into fall in blood pressure. Morphine effects on gastrointestinal system. Usually, you should never forget constipation. Constipation बिर्सिनै हुन्न है, nausea, vomiting and constipation. यो तीनटा कुरा चाहिँ morphine related drug मा लेख्नै पर्छ. Morphine मा त स्पेशली लेख्नै पर्छ. So increase in tone and decrease in mobility leads to constipation. They also decrease the concentration of HCl secretion. They also increase the tone in stomach, small intestine and large intestine. They also delay the passage of food, like that is gastric contents. So more reabsorption of water takes. This may all contribute to the effect of constipation. And tolerance does not develop into this constipating effect. That means one small dose and large dose will all result into equal frequency of constipation. Biliary tract, marked increase in pressure in the biliary tract, that is 10-fold increase over normal is about 220 mm water pressure. So by the use of morphine, there is a 10-fold increase in biliary pressure, increase due to the contraction of sphincter of OD. So urinary bladder, tone of detrusor muscle increased, feel urinary urgency but have urinary retention due to increased muscle tone where sphincter are closed off. Bronchial muscles, obviously bronchoconstriction are seen, so they are contracted in asthmatic patient, particularly before surgery. And uterus, they prolong labor, but they cannot be given as a relaxant, and because they are clinically insignificant. Important one, neuroendocrine effects, they inhibit the release of gonadotropin releasing hormone and corticotropin releasing hormone. That will influence lots of other hormones like FSH, ACTH, beta endorphin, LH. All secretions are decreased by the use of morphine. So as a result, the decrease of concentration of pituitary tropic hormones, the concentration of testosterone and cortisol in the plasma declines, and effects are seen according to the decline of these hormones. So the secretion of thyrotropin is relatively unaffected. So that means the use of morphine will not result the thyroid, will not affect or will not have any effects on thyroid gland. Except thyroid gland, I think it will affect all other glands and hormonal systems. Tolerance is seen in the morphine. Generally, it is seen in nausea, analgesic effect, sedative effect, and also seen in respiratory depression effect, cardiovascular effect, and euphoric effect. That means dose increases to produce same efficacy or same effect. It's called tolerance. If the dose increases to produce same level of effect, then we call it as a tolerance. And tolerance are seen on all these three: nausea, analgesia, sedation, respiratory depression, cardiovascular euphoric effect, but not to meiosis and constipation. And there is no tolerance on meiosis and constipation. Meiosis and constipation. Let me download. You should always mention, never forget, as an analgesics, Preoperative medications as post-operative medications in acute pulmonary edema. Why? Why in acute pulmonary edema? Because they result into peripheral vasodilation. They will result into shifting of blood from pulmonary to systemic. Allocation you see here, shifting of blood from pulmonary to systemic. That means obviously they will mobilize the fluid away from the pulmonary system. That's why they can be useful in case of acute pulmonary. In constipating, no, they cannot be given. It's a mistake. Constipating, they have a constipating effect and should not be given. They can be given, they have an effect as a cough suppressant, but the codeine has replaced the use of morphine. And in case of acute left ventricular failure, you should always mention the use of morphine. Analgesics and acute left ventricular failure. That means there is same effect. In case of acute left ventricular failure, they result to peripheral dilation, decreases preload, and due to peripheral pooling, that is shifting of blood from the pulmonary to systemic circulation. By depressing the respiratory center, which relieves air hunger, by being irresponsiveness to partial percent of carbon dioxide, and also inhibits the cardiac sympathetic stimulation workload to the heart. That's why they are very much useful in case of left acute left ventricular failure. दुईटा लेख्नै पर्छ, analgesics and acute left ventricular failure. Other you could mention in case of pulmonary edema and other things. This much for morphine, and this was for today.